Okay, so again, we're looking at another dermal process. I don't know if this was cut a little tangentially. The epidermis looks a little bit funny. But then we kind of have this sort of almost pedunculated papule. I would expect it to look like clinically. Lots of blood so far that you can see. Just very busy looking.
And what about this on the side? What do we call this structure here?
A collarette.
Very good. Yes.
And then looking in here, I thought that the sort of like fascicles of cells were moving through, and there's sort of blood cutting in between them. It's hard for me to describe it well, but I feel like this looks good for Kaposi's, just how the blood and the cells are sort of traveling together.
You described it perfectly. I like that description.
Thanks, Dr. Gardner.
Yeah, this is Kaposi. Very good. And you know, Kaposi comes in a few different kind of clinical appearances. There's a few different clinical scenarios and settings that Kaposi comes in, right? The kind of classic type, which is in the lower extremities of older adults. People had traditionally said it's more common in Ashkenazi Jews or people of Mediterranean descent, but I have seen Kaposi in folks of all different ethnicities and backgrounds. Older adults get lower immunity, and the HHV8 virus, which is pretty common, can take over and cause Kaposi sarcoma on the lower extremities particularly. Then we see it in the setting of AIDS. There's the endemic form that happens in Africa, aside from HIV, non-HIV associated, which I've never actually seen a case of that in real life just because of my practice setting. And then there's also the iatrogenic form in people that are immune suppressed, which you would think would be more common, but I have to say I've seen a lot of immunosuppressed patients over the years, and I think I've only seen one case where I think it was probably from the immunosuppression. So I don't know, but I think that that must be actually relatively uncommon, because considering the number of other immune suppression associated things I've seen in practice, I've only, I think, seen one immunosuppression Kaposi sarcoma. Most of the cases I've seen have been in elderly adults, the classic form of Kaposi. And then, so those are the different like types of Kaposi from their scenarios. Then there's also three kind of different stages, if you will, or presentations. There's the patch form, there's the plaque form, which looks like a plaque, and then there's the nodular stage of Kaposi, or kind of tumoral stage, if you like to think of it that way. And that's what we're looking at here, the nodular form of Kaposi. I have no way to tell what type of setting, if this is arising in a classic form in an elderly adult on the lower leg, or if this is because of HIV. I have no way to tell microscopically which one we're dealing with. But I can tell that it's probably the nodular presentation because it's a nodule, right? So I think it's important, much more important for pathologists, is to recognize the different patch, plaque, and nodule stages of Kaposi, because that changes how they look microscopically and clinically. All right? The nodular form tends to be a nodule like this. It can present with a collarette, which can make it look a little bit like a pyogenic granuloma, both clinically and microscopically at first glance. And I've seen cases that actually had PG-like changes or nodules of granulation tissue right next to an ulcerated nodule of Kaposi, which can create even more confusion. So when you see a spindly lesion with a lot of blood, right away think of Kaposi, all right? The one problem that does come up sometimes with nodular stage of Kaposi is that I've seen some cases where the blood is relatively minimal or even lacking. And in those cases, it can be very difficult to recognize that you're looking at Kaposi, because we focus so much on the blood-filled slit-like spaces between these plump spindle cells that are running in fascicles. It's like the classic appearance. And in nodular stage Kaposi, it is usually present. So it's such a great diagnostic clue, but every once in a while, this is lacking, and what you get is a cellular nodule that's got fascicles without blood, and you may scratch your head for a minute and be like, what on earth are we dealing with here? And so, like, for example, here, there's fascicles of spindle cells. They don't look, this is a poor quality H&E and scan, so we're kind of doubly hindered here. But they are kind of plump. They'll have mitoses, but usually they're not wildly pleomorphic. If you see a vascular tumor, even one that has slit-like spaces and blood, but looks super pleomorphic and ugly, you should think of spindled angiosarcoma before Kaposi. If you see something that looks like Kaposi sarcoma, but it's on the head and neck of an older sun damaged patient, that to me is angiosarcoma until proven otherwise. I don't care how much it looks like Kaposi, unless you prove it to me with the positive HHV8 in that context clinically, it is so much more likely to be angiosarc than Kaposi. So clinical context matters a lot. But we've got the cells tend to be plump and they have mitoses, but they're not usually very pleomorphic. There are some exceptions, particularly like in people with AIDS. There is a pleomorphic form of Kaposi. So if there's any doubt, do an HHV8, because even though Kaposi sarcoma and angiosarcoma, you might think, well, they're both vascular and they're both called sarcoma, so they're pretty similar, right? Nothing could be further from the truth. They are a night and day difference as far as treatment and prognosis go. I have a long video I did with my friend Josette McMichael, aka Global Dermy, on Instagram, and you can check that out on Kiko or my YouTube channel. And she goes through the clinical features of Kaposi, and I go through the path features. And it was really fun working with her because she and I know each other IRL before social media, because she was a senior resident at Emory in dermatology when I was doing my dermpath fellowship. And she's just a lovely person and an amazing, brilliant dermatologist. And it was such an honor to collaborate with her. So anyway, plump spindle cells, mitoses. What was the other point I was going to tell you? Oh yeah, Mark Edgar, my one of my soft tissue pathology mentors, taught me a really cool thing. We always focus on the fascicles with the slit-like spaces, right? Like you can see over here, like Grace nicely described, with the blood kind of tracking along in the spaces in the same direction as the spindle cells. I love that. But what happens if you cut a fascicle in cross-section as opposed to longitudinal? Well, all of a sudden the cells don't look spindled anymore. They look more round. And what happens to those slit-like spaces? They don't look slit-like anymore. They also look round. So this right here, what we're seeing is a fascicle cut in cross-section as opposed to longitudinal. And Mark Edgar said this is a sieve-like pattern. Instead of blood-filled slit-like spaces, it's like little round circles, like a spaghetti strainer, a sieve, a colander, whatever word you want to use for that, a pasta strainer that, has multiple little holes in the bottom, each of those holes filled with erythrocytes. So I love that because sometimes you won't see the good cut to get the fascicles. Here's a fascicle, and then here is the cross surface, the cut surface cut the other way, 90 degrees to the fascicle. So you can see them back to back here. Slit-like spaces, sieve-like spaces. Both of them are a great clue for Kaposi sarcoma. Usually you will see plasma cells around, and you can use HHV8 to support the diagnosis if you need to. I often do it because it's easily available in my lab, and it's such an important thing to get right, and it's such an easy single immunostain that solves the problem. All right. And you may or may not see patches or plaques in the background of the nodule. I would say more often when I see nodular Kaposi, if I go look next to it, I don't usually see patch or plaque stage next to it. I usually see a single nodule like this existing by itself more often than not. So that can also kind of cause confusion if you're, not expecting that. All right, very good. Oh yeah, the last thing. Kaposi is more a disease that we treat kind of managing symptoms or palliatively. You don't really cure it unless if you get someone's HIV under control or you find a way to reverse their immune suppression. But it's not a thing that we go and do wide local excision surgery on. You may remove some nodules of it for palliation or do various other treatments for palliation, but it is really a disease that is not cured in the traditional sense because it's virally driven. So it can be multifocal, not because it's metastasized, but because the virus is involving multiple areas of the skin. And also it doesn't usually metastasize. There are forms that can be more progressive and get into the organs and stuff. But most often when I see this, it's a disease that people die with rather than die from, if that makes sense. So again, it's very, very different from angiosarcoma, which is managed totally differently from that. So really important to understand that and to make that distinction between the two.